Good afternoon, everyone.
Yeah, good afternoon. Good afternoon.
I hand it over to you, sir. President of Karnataka Ophthalmic Society, all the three presidents are here. I hand it over to Dr. Y.L. Rajshekar, sir, to conduct the.
Thank you so much, Dr. Ilan. Good afternoon, everybody. This session is one of the most important sessions for which we have all been waiting. Today, we have two internationally renowned ophthalmologists from our country. We are proud to say that two internationally renowned ophthalmologists from our country, Professor Dr. Lingam Gopal and Professor Dr. T.K. Ramesh. They have been our teachers, models, role models. Many things we have learned from you, sirs. And you have taught not just the Indian community, but the international community. KOS, Karnataka Ophthalmic Society, is lucky to have two luminaries of your standing to deliver the Oration Awards. With this brief introduction, without taking away much time, a lot of audience are waiting to listen to you people. I hand it over to Dr. Ilan Kumaran.
Thank you, sir. At the outset, I'd like to welcome and thank everyone who has, particularly the oration speakers, Professor Lingam Gopal, sir, and Professor T.K. Ramesh, sir. First, we'll have Dr. Bhujanga Shetty oration by Professor Lingam Gopal, sir. Professor Lingam Gopal is regarded as a teacher of teachers in the ophthalmic fraternity. After completing the MBBS from Andhra Medical College, Visakhapatnam, and MS from PGIMER, Chandigarh, he went on to complete the Diploma of National Board, which we call as DNB and FRCS. He underwent fellowship training in the Department of Vitreoretinal Surgery at the Medical Research Foundation, a unit of Shankar Nethralaya, Chennai, under the famed Professor Badrinath, where he served for several years as a senior vitreoretinal consultant and in various other capacities as a clinician, as a teacher, as a researcher, and an academician. He served as the head of the Department of Vitreoretinal Services, as an assistant medical director, and later chairman of Shankar Nethralaya and director research. He also served as the head of Department of Neuro-Ophthalmology and president of Vision Research Foundation during his illustrious academic career. During the period from 1983 to 2011, he was continuously involved in the care of patients with vitreoretinal diseases and performed over 20,000 complicated vitreoretinal surgeries. He was involved in the care of patients with intraocular tumors also. Professor Lingam Gopal currently serves as an associate professor of National University Hospital, Singapore, where he continues his role as a teacher, innovator, and surgeon par excellence. He has mentored scores of vitreoretinal surgeons across the country and is best known for his research on ROP, retinopathy of prematurity, and coloboma of choroid and vitreous substitutes. In fact, the recent classification of coloboma of choroid is named after him. He has over a century papers in peer-reviewed national and international journals and has written 15 chapters in various ophthalmic books. He has delivered more than 130 lectures at various national and international conferences as an invited guest speaker. If I have to list out the awards that have been bestowed on him, it starts like this: Toleti Kanakarajo Shashti Purti Award, Colonel Rangachari Prize, Dr. Doshi Gold Medal, S.C. Datta Oration Award, Rustam Ranji Oration Gold Medal Award, Mr. Punshi Award for Best Researchers, Dr. Y. Greshwaradu Medal Oration Award, Dr. L.C. Datta Award from AAOS and AAOS Lifetime Achievement Award, Bombay Ophthalmic Association and the American Academy Achievement Award in 2008, and Jnanadakyam Award. Dr. Gopal is currently creating a learning machine to predict ROP, which is a software that should be able to predict the occurrence of ROP and fine-tune the screening strategy. He is also conducting studies on coloboma of the choroid and retinoblastoma. The majority of his research in retinoblastoma is at the molecular level, looking at various markers and possible target molecules for future treatment. Karnataka Ophthalmic Society is honored to give him the Dr. K. Bhujanga Shetty Oration Award. Sir, Professor Lingam Gopal, sir, over to you.
Sir, you are muted.
We'll play his presentation, sir. Sir has given this video. He's here also with us. I request...
At the outset, I would like to express my deep sense of gratitude and thanks for the Karnataka State Ophthalmic Society for having selected me for the inaugural oration of Dr. K. Bhujanga Shetty. Dr. Bhujanga Shetty is someone whom we look up to as one of the doyens in ophthalmology, and he has contributed enormously to ophthalmology across the country, and he has created an institute of international repute. So it's really indeed a very great honor to be able to deliver the first oration in the name of Dr. Bhujanga Shetty. So I really again thank you very much for this honor, and maybe you can play the video now. Outset, let me thank the organizers and Karnataka State Ophthalmological Society for giving me this opportunity to present the Dr. K. Bhujanga Shetty oration. Dr. Bhujanga Shetty is a doyen in the field of ophthalmology, and single-handedly he built the Narayana Netralaya that has risen as an institute of international repute. Throughout his career, he stressed the importance of quality clinical care, research and teaching as important founding principles. He has recently been named a legend in ophthalmology by Times of India in 2018. I would again like to thank the Karnataka State Ophthalmological Society for having given me this opportunity. I would like to dwell briefly upon the evolution of vitreoretinal surgery with special emphasis on internal tamponading agents, about which I have special interest. It all started with identifying retinal breaks in eyes with retinal detachment and trying to relate the two. And this was identified within 2 years of the introduction of direct ophthalmoscope by Helmholtz and Ruet with indirect ophthalmoscope by Ruet. But people didn't understand the relationship between the two, and they thought it is a detachment which caused the break. It was Gonin who related the cause and effect relationship of the retinal break versus the retinal detachment. A lot of credit for the present day vitreoretinal practice goes to Dr. Charles Keepens in Boston, who popularized binocular indirect ophthalmoscopy with indented examination. He developed several techniques, some of which probably are historical importance, but many of which we incorporate in our daily practice. He developed the technique of implant scleral buckling technique, open sky vitrectomy, etc. Most importantly, he has trained an army of retinal surgeons, stressing throughout on the diligence and meticulousness to detail. Coming to retinal reattachment surgeries, the initial attempts were always external in nature because vitrectomy was not in vogue at the time. Indenting the eye wall to approximate the retina to the retinal pigment epithelium was what was attempted. The initial procedures was scleral resection, as was done by Mueller, Lindner, and Chaplin. And rapidly it was replaced by indentation techniques without scleral resection using exogenous material. Jesse tried just simple gauze pad, and this was rapidly replaced by more tolerant materials because gauze tends to get infected over a period of time. Custodies developed the local plomb, and we now have a plethora of scleral buckling elements, both for localized implant and for encerclage. So the materials that form the scleral buckling elements have also developed over a period of time, from polyvinyl, polyester, etc., all the way to the present generation of solid silicon, which has stood the test of time. The next important step was how to create an adhesion between the retina and the underlying retinal pigment epithelium and choroid around the retinal break so that the break can be sealed once and for all. The initial attempts were by using cautery across the sclera. As you can well understand, the entire sclera is damaged and necrotic because of the cautery procedure. Similarly, full thickness scleral diathermy was also found to be very dangerous for the sclera, and hence Keepens developed the scleral implant technique wherein the scleral bed is dissected and diathermy is applied within the bed. With the advent of cryopexy, diathermy has fallen into disrepute, and at this point of time, perhaps diathermy is not even available. Laser photocoagulation has also come into vogue in a big way, both for use in the clinic, externally, and during vitreous surgery. This is a short video of a implant technique of Dr. Charles Gibbons, performed by my guru, Dr. S. Badrinath, way back in 1982. I will skip the more mundane steps and go to the important step of the scleral dissection being made. You can see the incision being made with the Dreschaber knife, and then the flaps are raised and the bed is dissected to the extent that is required based upon what implant is chosen. And then diathermy is applied within the bed at uniform intervals. And since diathermy causes more stronger adhesion than cryo, you don't have to make confluent burns. This kind of application is more than enough within the bed to cause adhesion. And then the mattress switches are passed and the scleral buckle is placed underneath the mattress switches. And encerclage is done as a routine and drainage is done as a routine. So basically this video shows us a technique which was adopted in the past for many years before it was supplanted by the explant technique and cryopixy. As I said, this is of historical importance and nobody does it these days. Internal approach to fix the retina was rapidly thought to be necessary because external approach cannot correct all kinds of detachments. The bands in the vitreous keep the retina detached despite a buckle, and hence Deutschmann tried to cut the bands by just using a knife penetrating through the ora. You can understand what the repercussions of this step would have been. Subsequently, people did attempt an open sky vitrectomy, and Hal Freeman even used a more controlled cutting off of the bands by using a scissors introduced to the pars plana and used inflated balloons under indirect ophthalmoscopic control. All this, of course, is of historical importance because of one man, Robert Markman. He has revolutionized the way we can manage vitreoretinal diseases. He has invented the vitrectomy system, and his initial tool is the vitreous infusion suction cutter, which is a multifunction probe of almost 18 gauge size, gigantic by today's standards. But it served the purpose and initiated us into the art of vitreoretinal surgery. There were other clones that were developed rapidly by Dowers, the roto extractor, and Payment's vitrophage. These were replaced by the Acutome system by Conor O'Malley, and this is a split function system. This perhaps is another important landmark in the development of vitreoretinal surgery, and the present day cutters are all clones of this Acutome system, be it 20 gauge cutters or 23 gauge cutters or 27 gauge cutters. We rely heavily upon the multifunction, we rely heavily upon the split port system. Although this vitrectomy approach could correct a majority of disorders which could not be attended to before the advent of vitrectomy, we still had difficulty in reattaching retina, such as in a giant retinal tear. People have tried injecting gas and positioning the head to unroll the flap, but vitrectomy followed by prone fluid air exchange has caught the imagination of the ophthalmologist. Prone fluid air exchange could be done in a controlled fashion using a striker's frame and a rotating table, which is not always available. And since we didn't have it, we had to innovate. And innovation we did. With the help of our anesthetist, the patient could be strapped to the trolley top, and then halfway through surgery, the head end of the patient is still kept under sterile drapes and turned in a prone position. This step is very, very vital in its planning requirement. Otherwise, it can result in disastrous consequences. And once the patient is in the prone position, the surgeon goes on a surgeon creeper, and does fluid air exchange using indirect ophthalmoscope through the pars plana using 30 gauge needles. And once the retina is reattached, we turn the patient back in supine position and inject oil in the air-filled eye. I had an opportunity to do 2 such giant retinal tears before mercifully Dr. Stanley Chang invented perfluorocarbon liquids, and then now the giant retinal tear surgery is child's play. The same holds good for the treatment of choroidal neovascular membranes, which is now currently done with intravitreal injections even by general ophthalmologists. But in the pre-anti-VEGF era and pre-PDT era, treatment of these were extremely difficult. And very often we ended up not offering them any treatment. Although some people even directly destroyed the macula along with the CMVM with photocoagulation. In this video, I'll show the submacular surgery which was sharply in vogue because of the inventions of Matthew Thomas, wherein he performed a vitrectomy, created a retinotomy, and detached the macula using DSS. And under the blood, we use a subretinal spatula to separate the choroidal neovascular membrane both from the undersurface of the retina and from the retinal pigment epithelium. Once the membrane is well mobilized, it is held with forceps and removed. As you can understand, since the membrane is plucked, it has got to be in front of the RPE in order not to damage significant areas of retinal pigment epithelium. And hence, this is applicable only for type 2 membranes where the membrane is entirely present in front of the RPE. So the two cases which I am showing here, not the videos but photographs, are of 10 people with idiopathic membranes which could be elegantly removed using this technique. And both had, fortunately for me, a good surgical result to stop retinotomy. This retinotomy need not be treated and can be left untreated with fluid air exchange. These are the two eyes of the patients with idiopathic membranes, both of whom have recovered very good vision subsequent to the surgery, got to see a healthy underlying RPE. Obviously, this is all of historical importance with the advent of anti-VEGF therapy. Coming to internal tamponading agents, Edward Norton introduced gases into vitreoretinal surgery, and we still use SF6 and C3F8 quite routinely. Stanley Chang introduced perfluorocarbon liquids, which, as I alluded to, has revolutionized the care of complex detachments such as giant retinal tear, retinotomies, retinectomies, etc. People needed long-term internal tamponading, which was provided by Paul Sibis. John Scott from UK used silicone oil as an instrument, not as a tamponading agent, but it was Jovanovic which combined the virtues of vitrectomy and silicone oil by doing vitrectomy with silicone oil being used only as a tamponading agent. Even currently, we use this combination for many complex detachments of retina. But are they ideal? Neither gases nor silicone oils fulfill the features of an ideal substitute. An ideal vitreous substitute should be easy to inject and easy to remove, or at least there should be no need to remove. We should be able to titrate the length of longevity in the eye. It should be optically clear so that patient can see postoperatively, and we can also do laser, etc. Postoperatively. It should be able to obviously support the retina and permit retinal reattachment. It should have no mechanical or toxic effects on the retina and should not cause cataract or glaucoma. Ideally, there should be no need for special posture and there should be no restriction on air travel. Now, none of the substitutes we have currently fulfill these criteria. So there's obviously need to try and identify newer substitutes. Our foray into field of tamponading agents was kicked off by this collaborative effort between myself, Professor Su Zinni, who is the driving force behind this whole project, and Professor Lo Sin-chun, who is a polymer scientist of repute, supported by a good team of scientists. And we zoomed down upon smart hydrogels, which are thermoreversible polymers. They are liquid in cool temperature, and when they touch the human eye, they become a gel. So they're easy to inject, but in the eye, they become a gel. And the transition temperature is tunable. These are transparent, they are biodegradable, hence no need to remove, and obviously easy to inject when they are cold. So the product we chose is a patented product, a patent of Professor Sin-jun, and is a tri-block polymer containing polyethylene glycol, polypropylene glycol, polycaprolactone. It is thermosensitive, optically clear, with a refractive index of 1.34 and is entirely biodegradable in a matter of about 2 to 3 months. At about 16.3 degrees, there's a transition between salt to liquid, salt to gel, and it has got a viscosity which is much higher than silicone oil. The current tamponading agents function by flotation force and buoyancy, while the hydrogel acts by swelling counterforce. And hence, potentially, it can tamper out inferior breaks as well, and perhaps does not need special posturing. As you can see, the surface tension of this gel is nearly 10 times that of silicone oil at 37 degrees centigrade temperature. This is the initial experiment in the rabbit eyes, wherein we performed a vitrectomy. This is triamcinolone, which is used to facilitate vitreous detachment. And in rabbits, you know that medullary ray has a strong attachment to residual vitreous, so you cannot remove the entire vitreous from the vitreous cavity. Following vitrectomy, we're injecting the transparent gel. You can see the injection being done to a 25 gauge cannula very comfortably, and it's an absolutely clear, optically clear gel. And following that surgery, we evaluated these rabbits at periodic intervals, and it has not shown any toxic effect to the retina. And evaluated on OCT, you can see all the layers intact, and evaluated histopathologically also, you can make out all the retinal layers are intact, compared to the unoperated eye on top and an operated control where no gel was injected. Once we were encouraged by these preliminary results, we chose to perform surgeries on non-human primates, wherein we did a retinotomy, detached the retina, and then created a retinal break, which was sealed with endolaser following a reattachment and fluid air exchange. Following surgery, as you can see, evaluation on fluorescein angiography, autofluorescence, and OCT showed that the macula is perfectly healthy and the retina does not show any signs of toxicity. The same were confirmed by electroretinography, wherein both on scotopic ERG and photopic ERG, the waves are well maintained. We also found something interesting in the rabbit eye. Following the hydrogel injection, when the eye was removed nearly 6 months later, we found something mimicking a vitreous gel. We were really puzzled by what exactly this material is, because it's almost as if we have not done a vitrectomy. It's very, very sticky. As you can see, it's being cut with a knife. Well, contrast this with another eye where vitrectomy was done, but no gel was injected. You can see that this material can be easily sucked with a cannula compared to what I showed you earlier. So this material was then studied. The NMR studies of this material showed that there was definitely no residual hydrogel, which is the first thing we suspected. None of these segments of pure hydrogel, ethylene glycol, polylactone, etc., were not found in this material. And mass spectroscopy of this material showed that the proteins are similar to the native vitreous gel in terms of the types of collagen, non-collagen structural protein, hyaluronic acid binding proteins, heparin, and chondroitin sulfate proteoglycans. So we really don't know what exactly has happened, but it looks as if a vitreous-like material is being generated as a reaction to the presence of the hydrogel. If this were true and it is consistent, it will be a very good boon to offer, because this artificial vitreous can actually support the retina permanently long after the hydrogel has been removed from the eye by biodegradation. In monkey eyes, we could not replicate this part of the study. So the preliminary results were reported in the Nature Biomedical Engineering, and further studies are on to try and refine this product. So the lessons from history are that change is expected, and major innovations come once in a while, but minor improvements are equally important. One should adapt to the change, but also understand that not everything new is good. So before we adapt, we have to assess whether it is really right to change or not. For this, the golden mean of Aristotle comes in handy. Herein, we don't go to any extremes. We try to have a balanced view, an unbiased view of anything new development, and then try to incorporate it into our routine practice. But we don't stumble because we try to incorporate them too soon into practice before it has been tested well. So in conclusion, vitreoretinal surgery has come a long way since the introduction of closed vitrectomy by Robert Markham. Many hitherto untreatable conditions have fallen to the vitreoretinal surgeon's knife. But the absence of a good vitreous replacement still remains an irritant. And we hope that the thermoreversible hydrogels that we alluded to may hold a promise as a future vitreous substitute. Thank you very much for your attention.
Thank you so much, sir. It was an excellent talk, not just a talk. You have shown us the spirit of how to unlearn, relearn. You know, it's a continuous process of learning. It's a great source of inspiration for all of us and many of the youngsters who are in the program. I request Dr. Hemant Murthy, Dr. Kudlu, and Dr. Patil to share their views and thanks. We are missing in this online. We are able to have you. If it were to be offline, we would have had the aura of your presence also. We are missing that, sir. Soon we are going to have you in a greater this thing, and we request you to accept our invitation in the coming years or months to Karnataka Ophthalmic Society, sir. Over to Hemant.
Yeah, thank you, Dr. Lingam Gopal. As usual, your talk is always very interesting. And I could see your talk showed how we changed from GA to local for most of our retinal surgery. I could see the GA tubes in one of your surgical videos. We have changed from implant to explant, surgery for CNVM to anti-VEGF. I think you have shown us how history has, of VR surgery in all. I was really intrigued by your work on hydrogels, because I think that's what is going to be very important. I was curious, when you showed that, something that vitreous that comes in after the hydrogel disappears. Is it similar to what we see in our practice also? After we do vitrectomy, after a few months, you see that the vitreous becomes thicker and starts looking like a gel, it looks a little more thicker than what the fluid that we leave behind. Do you think it's similar to that, or is it something very different?
No, the vitreous-like fluid which forms after vitrectomy in a human eye, we always find that can be easily sucked even with a 30-gauge needle. Means there are some proteins which got added up. We all know that the balanced salt solution which we leave behind is removed within about 6 to 8 hours. And after 6 to 8 hours, it gets filled with aqueous-like material, but add on some amount of proteins. That's why it's a little more viscous than a BSS. But it's not anywhere near the viscosity I have shown in this picture, because this was almost like a gel. We had to cut it with a knife. So that was very, very puzzling. So we don't know exactly whether we can replicate it in higher animals, because at this point of time, we were not able to replicate it in monkey eyes in the repeat setup. It's only in the rabbits that we could get it. So it's just a spin-off. That was not the main purpose of the study, but it was just a spin-off, which is an observation.
Thank you, sir. Thank you. Very interesting topic. I think we would be very happy to hear more of that in future years.
We sincerely hope that we can bring it up to a level where it can be really useful clinically. But we are still working on a lot of small issues like how to sterilize it and how to package it. These are all lots of issues which are very important ultimately if it has to stand the test of the testimony of the investigations.
Thank you. Thank you, sir.
Thanks, Dr. Hemant.
So, Dr. Krishna Prasad Kudlu is the secretary of Karnataka.
It was really wonderful to hear from Lingam Gopal sir. When I still remember that sir was in Singapore National University when I came for to learn some presbyopic surgery from this thing. That time only the name what sir had got, the level of sir's surgery was still, I remember. When we were small also, I think ophthalmologist early part, we still remember sir operated, I think overnight, when Sabah Karim had a injury from the Anil Kumble's ball in the Dhaka cricket and came all the way to Lingam Gopal sir and he operated. I think it was really pleasure hearing you, sir. You are still like, even in this age also, you are still innovative and to get more and more into ophthalmology, sir. Thank you, sir.
Thank you. Thank you.
I think what we observed, sir.
Age is no bar for learning. So I think you should never get it into your mind that I am old. You can be physically old, but you are never mentally old. So correct. I think we should definitely try to contribute to the society at large as long as we are able to physically function.
Thank you. Amazing. That's a great point, sir.
The sir is very busy today, sir. Despite that, he agreed to our request. That was a short notice.
Yes. Thank you so much, sir. Thank you so much. And telling history and being part of history at each step, that's amazing, sir. You have done all those steps, whatever you showed, and it has, the subject has evolved so much. Thank you so much, sir.
Thank you.
Yes.
Thank you.
Thanks a lot. With the thanks to Professor Lingam Gopal, sir. Now we come to the second oration of the day. Dr. Sri Ganesh oration. Who else? Dr. T.K. Ramesh, sir, or fondly known as TKR, sir, or Dr. TKR to all of us, is an ophthalmic surgeon and academician par excellence. After completing his MBBS and MS in ophthalmology, he went on to complete DNB and then FRCS Edinburgh. After completing a fellowship in cornea and external diseases of the eye from the University of Rochester Medical Center, USA, he was a clinical observer in the Department of Cornea and External Diseases of the Eye, Massachusetts Eye and Ear Infirmary, Boston, and had a clinical attachment as the Queen's Medical Center, Nottingham, England. Dr. TKR, sir, has been a visiting professor at Arvind Eye Hospital, Madurai, India. He has previously been the director of the Regional Institute of Ophthalmology, professor and head of the Department of Ophthalmology, medical superintendent of Minto Ophthalmic Hospital, Bangalore Medical College and Research Institute. He currently consults at his own center, Ramesh Eye Clinic and Ophthalmic Microsurgical Center, Bangalore. Dr. TKR, sir, has been and continues to be a mentor for several postgraduates and fellows. He has keen interest in the treatment of diseases of the eye with a special focus on anti-segment diseases of the eye. His community work includes camp surgeries for cataract training of ophthalmic surgeons and paramedics for field work and development of strategies for disability limitations in corneal diseases. As regards the awards, Dr. TKR, sir, has been the recipient of several awards, including Dr. Bashir Maikris Award, Dr. Muller Patton Award, the Best Video Presentation Prize and Best Scientific Poster Prize awarded by AAOS in 1990, and Dr. Krishnamurthy Award. He has been conferred the title of Netra Ratnakara by His Highness Sri Vidyamanya Tirtha Swamiji of Polymer Mutt at Purna Prajna Vidyapita in 1997 and had been elected for the Fulbright grant in 1988. Dr. Ramesh has been given the award for excellence in 2003 by Karnataka Ophthalmic Society. He won the best paper for cornea in 2003, and then Dr. M.M. Joshi Best Paper Award was given to him in 2004. That was the first time when Dr. M.M. Joshi Best Paper Award was instituted by Karnataka Ophthalmic Society, and that's the first year I came back to Karnataka also. I was third behind, sir, in that list. The B.C. Roy Doctors Day Award was conferred to him by the IMA of Bangalore in 2005 and Aryabhatta International Award in 2010. The B.C. Roy Doctors Day Award by the government of Karnataka was offered in 2010, as well as the Vocational Excellence Award, Rotary International. The Dr. G. Sita Lakshmi Gift of Sight Award was presented by Lions Club of Madras in June 2011. The Karnataka Ophthalmic Society is proud to give this oration, Dr. Sri Ganesh Oration Award to Dr. T.K. Ramesh. Is honored and proud to. Over to you, sir, Professor T.K.
Please, sir.
Can you hear me, Ellen?
Yes, sir.
Can you hear me? Thank you,
Yes,
Dr.
sir.
Ellen, for the kind introduction. Let me share my screen. Is my screen visible?
Yes, sir. No, not it, sir.
No, sir, not it, sir, not it.
Thank you, Dr. Ellen, for the kind introduction. As Dr. Hemant is getting ready to show the slides. Respected President, Dr. Ellen Kumar, Convener Scientific Committee, and members of the Karnataka Ophthalmic Society and dear delegates. At the outset, I'd like to thank the KOS for selecting me for this oration.
Can I share the screen now?
Yeah, please. Over the years, Karnataka Ophthalmic Society has done yeoman service in conducting conferences, teaching programs for the benefit of all the ophthalmologists. And today's program is no different. On this For this Sri Ganesh oration lecture, I'd like to remember and thanks to Dr. Sri Ganesh, who is a surgeon par excellence, academician, entrepreneur, leader, and he's such a good surgeon that it's always a pleasure to watch his surgeries. He has started several teaching programs, fellowship programs, and it has benefited large number of young ophthalmologists. He has established a series of hospitals called Netradama hospitals. Thank you, Sri Ganesh. Next slide, please. Next. One thing which has bothered me, or the dilemma which I've faced over the past 3.5 decades as a teacher, is when we are teaching surgery, when we are putting patients' eye at risk, how do we balance the two objectives? One, to safeguard the patient's interest at all costs, and at the same time, give opportunities for the younger generation to learn surgeries. How can we achieve both these objectives? This is the crux of my talk, which lessons I have learned of how to teach and how to learn ophthalmic surgery. We all know the methods which are adopted regularly, like videos, CME programs, wet labs, simulation surgeries, assisting, all that. I'm not going to delve into that. The next stage, when from assisting to actual performing the surgery is a big step, and things can go wrong if we are not careful. Unlike other branches of surgery, the eye is a very small structure and only one or two instruments or one person can be operating at a time. The other person, the teacher, can only be observing. So we need a robust method of transferring from assistant to actual surgeon. We have to be very, very careful and we have to have a definite plan. Next slide. So what are the principles and practice of reducing or eliminating the risks to patients while teaching ophthalmic surgery? Next slide. There are several factors which contribute to the risks. The risks can arise from the trainee, his competence, interest, honesty, and willingness to learn and aptitude. And the trainer, how well the trainer is trained to train and how much interest the person has got to train and put up with the delays, complications, and all those things of the trainee doing the surgery. The exact skill or the procedure which is being taught is crucial, because if the skill or the procedure which is being taught is easy to learn and is not such a risky procedure, it's easily taught and learned. While on the other hand, if it's a procedure which requires excellent skills or it is a very unforgiving step, then one has to be very careful. How we teach and how it is taught is extremely important, and this aspect will form the crux of my talk. The setting in which teaching and learning happens is very important. How much time is available, what is the workload, what are the facilities available, what are the supporting staff available. These are also important in this learning teaching exercise. Next slide. Over the years, we learned few lessons, as I mentioned. Along with my colleagues, we devised this module of cataract surgical training. As an anterior segment surgeon, most of my examples are of cataract surgery, and that's relevant to most of the audience. The same principles can be applied for all types of ophthalmic surgeries. Next slide. The first thing is to divide the surgery into several steps. Each step can be further subdivided into sub-steps, and learning and mastering the sub-steps reduces the risk to patients. Every step has a sub-step, and every sub-step has a micro-step, which we have to understand and which we can master and mastering the basics will reduce the risk to the patients. Next slide, please. Let us take the example of cataract surgery, starting from patient position to wound closure. Next slide. I have several steps. If we take only the rhexis, we need to dilate the pupil, stain the capsule, we need to prepare the capsulotomy needle, we have to enter and exit the eye, and actual doing the rhexis. Preparing the capsulotomy needle has its own steps, and this is a very forgiving step because if you do a wrong needle bending, you can always throw it and take another one if you have not gone to the next stage of entering the eye. But actual rhexis is less forgiving, more critical to do it properly. This is just an example of how steps and micro steps vary in their complexities and importance. Next slide. I stress too much on the dress rehearsal. It is almost like getting ready for acting in a drama that you need to do dress rehearsals for whatever surgery or whatever steps you're going to do. Actually wearing the surgical gowns, gloves, sitting at the operating table with all the furniture, assistant and positioning of your equipments and reaching the foot pedal is critical. And I urge the students to do this on a day when there is no surgery and get used to all these things because these things should not occupy the mind when the phaco probe is touching the nucleus. Next slide. Mental preparedness and alertness during the surgery. Very often we see a mistake happening and then the student or the teacher says, oh, I thought, I knew I should have done like this, but at that moment I forgot. How can we overcome this? For this, every step, micro step of the surgery, we need to answer 5 questions. What should be achieved at the end of that step? How should it be achieved? What all can go wrong and how to prevent them? How to recognize it's going wrong and how to rectify if at all it goes wrong. Now these things have to be by heart for every step of surgery which you are going to perform on that particular day. And I urge my students, just before performing the step, just like a prayer, they have to say to the teacher, all these 5 steps, the 5 questions have to be answered to understand that he remembers on that particular time. In a multiple choice question or an exam, 1 wrong out of 100 gives you a first rank, but in surgery, 1 wrong out of 1,000 gives you a big 0. So all these 5 questions have to be memorized well in advance and at that particular moment, in spite of the stress of doing the surgery, that has to be remembered. Next slide. What is the risk reduction through alteration of techniques? Whatever surgeries we are doing, we do because we are used to that and there are some shortcuts or some procedures which we do without thinking. But that's not true in case of teaching. For example, cortical cleaning is a step where high risk of posterior capsular rupture. Instead of using irrigation aspiration, fill the anterior chamber with visco and initial few cases do only aspiration so that the anterior chamber shallowing and catching the posterior capsule is minimized. This is just an example of how techniques can be altered to aid the student to win into learning surgeries. Next slide. Monitoring during surgery, early recognition of things not going according to plan and prompt correction of the course correction is extremely important and is the responsibility of not only the student, but more importantly, the teacher who is constantly observing the student doing the surgery. Next slide. Post-operative discussion and rectification, extremely important. Documentation, notes, videos, reflection and reliving the surgery, discussions and confessions are most important in learning the surgery to get better. Confessions are sometimes forgotten and mistakes or complications are just put under a cover that does no good for anyone. Next slide. Next. Mastering the surgery without performing the surgery. Is it really possible? I'll give you an example. If somebody wants to graduate to toric intraocular lenses, the fear is what if it goes into the wrong position and compromises the surgical results. In regular intraocular surgeries, as an initial step, we do all the toric intraocular lens calculations. The regular spherical IOL implant is done after marking intraoperatively and positioning the lens properly using the haptics as a marking on the lens. And post-operative results are evaluation for a series of cases. And before performing the first toric intraocular lens, we know that how things happen and how easy or difficult it is to position the lens and what our results are. And before performing the first toric IOL, you already mastered several of the steps of toric IOL, and your chances of making mistakes and increasing your results are excellent. Next slide. Let me give an example of intravitreal injections. It's only one person can inject, and a mistake happening touching the lens or touching the retina or wrong position can be disastrous. So in regular surgeries, cataract surgeries, we can practice some of the steps without compromising. Load the drug into the syringe. Drugs are very expensive. You can't learn by loading the actual drug. You can inject a small quantity of saline into the empty vial, drawing into the syringe, measuring the appropriate quantity, preparation and marking the injection site using the calipers. In few cases, take a syringe without the needle, connect a blunt cannula, touch the sclera where you want to enter, move the conjunctiva appropriately, and then assess your own grip and direction, and your stage is set for taking the final plunge of doing the first case of intravitreal injection. I'm sure you'll come out with flying colors. Next slide. Refractive surgery, epithelial removal from C3Rs can be a good learning. Surface ablations, microcuratum handling. You have to handle the microcuratum in the OT on a day when you don't have cases posted. Know everything about handling it. And on the patient, initially, you can just place the microcuratum for a few patients. Build up the suction, but don't make the flap, don't cut. Abort it, and the teacher can take over. And once these steps are mastered, then the final day when you make the cut, you'll get a perfect flap. And then you can graduate to femto flaps and handling the cones. Next slide, please. So in short, planning and practice is the key to mastering surgery without risk to patients. Responsibility to our patients to see that their interests are not compromised. We have a responsibility to our students so that they learn, and we have an army of surgeons. We not only by this technique train surgeons, we also train them to become teachers so they can carry on the legacy and they can train their next generation. So these principles can be applied for any ophthalmic surgery, and I hope this is of interest. And before closing, I'd like to appreciate all the institutions, both private and government, which are running various training programs. It's really a big task. They're doing yeoman service, and they're taking a huge risk by training the surgeons. And with these techniques, everyone will be helped. Thank you very much.
Thank you, Dr. T. K. Ramesh, sir. You have been our teacher from our MBBS days, and you continue to be our teacher. Your meticulous way of thinking, analyzing a task, and cutting it into minor steps, asking right questions, and encouraging people to learn and do new things is amazing. We have been greatly benefited by that, and you have very well shown all that thinking processes in this talk. This kind of thinking process and analyzing a situation, we can apply at various operational levels and various situations in a day-to-day learning of a hospital also. It's a great learning experience, sir. Thank you so much. Dr. Hemant, Dr. Kudlu.
Sir, it was really fantastic talk by T.K. Ramesh, sir. And I keep following him most of the time. I had a privilege to work with him that when Mr. Sharan Prakash Patil was the medical education minister, he made me one of the unofficial advisor to his department. So I could able to travel to sir. I accompanied his sir many times to minister's office, but in that age, sir was about to retire. I still remember 2 months. But what sir was telling me, no, before I go, all the equipment has to be there in Minto. Make sure that it has to go to the best of the best knowledge, and Minto has to be the best eye teaching hospital in India. That was his dream. He was telling me many a times, because as we all know that India's second oldest hospital is oldest eye hospital is Minto Hospital, apart from our Chennai hospital. So sir was very much keen that we should have all the hospital, and that time also, once I still remember, he took me to the department. How much in between when PG came, he was going and in front of the slit lamp, he's teaching them all the finding in the cornea. I think it was really great to work with you for a very little period, and I'm always been your follower, sir. It was wonderful.
Thank you.
Thank you, Dr. Ramesh. I know I've been fortunate to assist you in some of the surgeries. Long back, I still remember your...
ಬಯಸ್ಕೊಳ್ಳಿಲ್ವಾ ಹೇಮಂತ್?
Not as a student. I just because I had asked him to do a lamellar keratoplasty in one of my patients, so Dr. Ramesh came and did it in the hospital. I have a different association with Ramesh. Mostly
he's very strict teacher, very very disciplined, very strict, dedicated teacher.
I like the way that whenever he did a surgery, he always used to come out and then see what all did he do. Was it something he could do differently? See, the way that you analyze each case, actually that is what makes you a good surgeon. You should plan for the surgery. Once you do your surgery and you finish the surgery, come out and think, have I done all the steps that I thought I would do? Is there something I could do better? And the next time that you would do a much better surgery. So each surgery you tend to improve, and that's what makes you a good surgeon. He's an excellent surgeon. I've seen the way he handles tissues. I think all of the students should just watch him do surgery and learn the skillful way that he manages the tissues in the eye. Thank you, Dr. Ramesh.
Thank you, Hemant.
Sir, thanks a lot. At the outset, KOSCON thanks the two awardees. Professor Lingam Gopal sir, despite his busy schedule, he kept some time aside for us. And Professor TK Ramesh sir,
thank you,
who also took time away from his busy schedule. I also would like to thank President Y.L. Rajshekhar sir, incoming President Dr. Sadanand Patil sir, and Vice President Dr. Hemant Murthy sir, and immediate past President Dr. N.S. Muralidhar sir. My dear friend Dr. Krishna Prasad Kudlu, who has stood with me throughout this conference and for this oration and collected a lot of money for us for also this. Again, he only collected. I thank him also. Dr. Chaitra, Dr. Rashmi Jain, who stood with me for preparing all these sessions, I thank them. Finally, I've kept Dr. Sunil Ganekal for the end, because he is the one who stayed with me for this past almost 1 month, almost every day we used to call. And along with that, I would like to thank our secretary, Mrs. Asha also. Thanks a lot to one another.
Thank you, sir.